Good morning, everyone. This is Dr. Chhabra. I am the Chief of Musculoskeletal Division at UT Southwestern. This is our part 2 of a series of hip reconstructions, advanced imaging processing, which we are showing both on CT and MRI. This is the second of those lectures, which will go through different measurements, how to do them and put them in your structured report if you're using in your setup or you're planning to use. And this is becoming more and more popular, and we do a lot of these cases on a daily basis. So I will encourage you to go to the first lecture and look at how we did the reconstructions, how we did the individual segmentations, and also showed you in that lecture how to do the bump area. So we'll focus in this lecture more on the measurements, and I'll show you how to do the top-down cutout view, where you can first look at the images grossly, how they are, how the person's pelvis is arranged and the head is uncovered or covered, and then we'll move on to different measurements and show you how to do those measurements. So when you load this case, just like the first lecture I showed, the pelvis gets loaded into all these three planes as well as this volume rendered image. And if you zoom in on this image, basically to obtain the cut down view, you'll have to make the cuts above the acetabular roof. So first we align the pelvis and look at it grossly. What's the distance between the pubic symphysis and the sacrum? So in women you can have up to 4.3 centimeters, in males you can have up to 2.3 centimeters. That's kind of normal sagittal balance, how the sacrum is oriented relative to the pelvis. Now in this case, this happens to about 4 centimeters, which is good. There is no anterior pelvic tilt where the sacrum is high up, or there is no posterior pelvic tilt where the sacrum is lower down. So this is adequate pelvic tilt. Next thing you want to look at is the pubic symphysis lined up with the sacrococcygeal junction? If it does, then there is no side-to-side rotation. So we looked at the sagittal rotation in the first place by this distance. Now we look at side-to-side rotation. It looks like there is no side-to-side rotation, so that's good. Then we focus on the acetabular roofs and see if they're sloping up. This looks like it's a little bit sloping up. This looks like it's a little bit sloping up. It's not like the flat roof we are used to. So there is some dysplasia going on both sides. Then the next thing we look at is how much of the femoral head is out of the acetabulum. Is it more than 18%? In this case, it looks like here it's a little more than 18%, and here it's also a little more than 18%, but less than the other side. Now, in order to obtain the better view looking from top down, what you have to do is use the free ROI. We can minimize this a little bit so we cut it better, and then use the shift key. And basically you're going to cut it just below this anterior iliac spine and cut it out right here, and then remove all of this. So now we can pan it and zoom it a little bit and rotate it. Once we do that, now you can see from top down how the femoral heads are. So at this point you can do a smooth surface, which will remove these jagged edges, and now you have acetabulum on both sides, right? And you can see that this head is more uncovered than that one, but both are slightly more uncovered than usual. So we can take that image, and you can press C to get an image, and you can label this as top-down view. And you can rotate it a little bit like this way. Take another image. Again, you can press C, or you can press this camera shot right here, and then you can rotate the other way so the surgeon can see the anterosuperior extent. Here it is. Now you want to orient it a little bit better like that. Take that view and then show it this way and show it that way. So now you can show those images, as well as you can look at the bumps, and you can see there's a little bit of bump here. And usually in dysplasia cases you get more infralateral bump rather than more anterosuperior and superolateral as you get in FAI. So here is a tiny bump here also. There's a small bump there, and there's a small bump there. So you can see these take that image as well. So once you have taken these images, you can go to your output panel. All these images are there. You can do Control A, select all, and then send them to PACS, as I showed you in the previous video. So you right click, select all, you can do that, or Control A, send it to one of your PACS. So now we'll delete these. So we want to send all the measurements as. So now I'm going to show you how to do measurements. So we'll start with our first measurement, which is the center edge angle. Now in order to measure that, first we have to focus on one of the hips. So in this case, let's focus on the right hip. So I'm going to magnify that so you can see it. Now you can do a center edge angle anterior, which will be here, right where the obturator internus externus is. You can do it in the middle. You can do it posterior. And when you do it on the x-rays, it's usually superimposition of all the bones. On the CTs or cross-sectional images like 3D MR, you're going to miss it, the upsloping of the acetabular roof. You're going to miss that if you do it in the center or posterior. So you have to come a little bit anterior. That way you can see these slopes, which are altered slopes. It's not like a flat slope you're seeing. And usually the recommended is that you come anterior. Now you can see the pubic symphysis. You can see the superior pubic ramus. And you look for a notch here when it comes up. So right here, the notch starts coming up. So at this point, one should do it. And in order to do what's called a center edge angle or a tonus angle, first what would you do is you take this sourcil, this white line of the acetabulum, you take an angle from one point here to the other point where it finishes, right about here, and then you draw a straight line. So here you can see the tonus angle is 16 degrees. So normal is about 4 to 10 degrees. If you have more than 10 degrees, that's dysplasia, like this case is. Or if you have less than 4 degrees, now you're getting into overcoverage territory. So this is how you would do the tonus angle, with a straight line like that, just a little bit like that, 15.8, and then the top going up and down. Now in order to do a center edge angle, we'll delete all these measurements here, and then every time you take a measurement, you can take a capture here by pressing C or the camera. So now in order to do the center edge angle, what you have to do is draw a circle on the head. So let's try that, like that. Now you have to get the head inside, not too big, okay? So that's a good circle there. It doesn't come out there, doesn't come out there. And now you know the center also. You don't need this palette, keep it on the side. Now at this point, we have to draw an angle, and that angle would be the straight line going up to that center point and then going to the lateral acetabular edge, basically at the sourcil. So sourcil is here. This line has to be a little straighter, like that. And you can see the center edge angle here is 15.6 degrees. So the normal center edge angle is anywhere from 20 to 39 degrees. So less than 20 is dysplasia, like this case. So mild dysplasia is 15 to 20, moderate to severe is less than 15. And then, so this is sort of getting to moderate dysplasia. And if it's above, it's between 20 and 25, in that case there will be borderline dysplasia. There's a lot of interest in research in that arena. And then 25 to 40 is normal, or 25 to 39. And more than 39, you have overcoverage. So this is how you would do the lateral center edge angle, which was initially done on X-rays as a lateral center edge angle of Weiberg. This is the lateral center edge angle on CT scans, which is pretty much similar to what you get on X-rays. So this is the second angle. The third angle we have to do, we can delete all these measurements again. Click on the measurements. Now the third one is the alpha angle. So alpha angle is kind of tricky how to do it. So for that, we have to see the sagittal plane as well as the coronal plane, and we have to get the axis of the neck. In this case, I'm rotating it. So here you get the axis of the neck here, right like that, going right through the neck, the barrel of the neck. You bring this here, and now it's going through the barrel of the neck on the sagittal view. And now we have a perfect circle here, which is basically the head and neck junction, right here. a little bit like that. So this is kind of tricky. Which position is what? You know, are you going to use this or that when you measure your alpha angles? Well, when you have a 12 o'clock position, which is this position, at 12 o'clock position, whenever the hip looks like a AP view of the pelvis, like this case, this is your 12 o'clock. So at this point, what we have to do is, this is your 12 o'clock. You have to make a circle. And again, you use your circular ROI right here. Put that about there. Take an angle from here, right to the barrel of the neck, go to the center. And then you have to get out where the head and the neck junction gets out of the circle. Now in this case, not getting out, right? It's inside. So what we have to do is you have to finish where the physeal scar ends. So this is a physeal scar sloping down, it's ending here. So basically the alpha angle here is about 60 degrees or so. Now you can always go like this and think that could be the head and neck junction. You could do that. So there is some variability there. I usually finish when the physeal scar finishes. So about that particular area, 60 degrees if the head doesn't come out. And we can take a picture of that, and then you can always label it also. So you can put here 12 o'clock and then take a camera picture there, and you can label it as alpha angle right here, and that gives you that picture. And the surgeon knows, and when it's AP view, that's going to be the 12 o'clock. Now, in order to get 1 o'clock or 2 o'clock, remember look at carefully where the anterior portion is. So here is the anterior portion of the pelvis. This is the posterior portion of the pelvis because there is ischial tuberosity. So 3 o'clock is always anterior. So we're going to move in the clockwise direction for this right hip. In the left hip, you have to move to the anti-clockwise direction. So now we go here. This is the 1 o'clock. Now we really don't have a clock face here. So you really have to imagine, and I've been talking to TIRECON folks if they can put a clock face here so we can be more accurate. But this is sort of looks like the 1 o'clock. And now you go back here and you can adjust these circles. So you can bring that circle back to where it should be. And I have to remove all of this. And let's move the circle right here like that. So now this is a circle and you have to adjust the lines. This is in the center and this has to be adjusted like that. And you can bring this line. Now where do you exit? In this case, exiting right here about that, right? So at this point it's 67 degrees. So usually most of the bumps or the larger measurements you're going to see, they're usually at 1 to 2 o'clock. Okay. Now one may say it's here and one may say it's here. But these are minor variations. You know, you can get it right about here. It's about 69 degrees. So we'll take that picture. That's your 1 o'clock. Now we can go to 2 o'clock, do the same exercise, which is about this. And then again, move the lines and move the circle if it gives me an option. Actually, it's not giving the option. Moved a little bit. That's another line. Okay, I can redraw it if it doesn't give me the option. You can always do that. Bring the circle there. Now it's giving that. So we go to the center, which is this. Bring it right about here. Then bring this line here. Now the question is, where are you going to get it? Well, it seems like it should be here, it's getting out, right about here. So that's your physeal scar ending, and this is where it's getting out. So it's about 61 degrees at this spot. So you can take another image there, and then for the 3 o'clock, it's going to be horizontal like that. And then you take another measurements. Same way, you can bring it there. So basically, that's how the measurements are done for the alpha angle. Now if you do it in this way, there will be less variability. Otherwise, you know, sometimes you have a hard time where the neck is getting out. So in this case, it's getting out right about here, 56 degrees. So usually you will see 12 o'clock is a smaller measurement and 3 o'clock is a smaller measurement. Basically you're getting to normal on either side. And in this case, 56 degrees. Okay. So we'll take that image. That's a 3 o'clock image. So we're done with the alpha angles. Now the next thing we have to do is the AP center edge angle. For that, we have to reset it. We have to go on the sagittal plane, magnify it, go here.
Can we pause there?
Yes. Okay, so next thing we're going to show you is the AP center edge angle. For that, we'll delete our earlier measurements, these ones, and we'll go to the sagittal image. Pan it so you can see it better, magnify it. Now here the question is again, do you take it here, do you take it there, like which plane or which area is better to do it? So in such cases it's more of a guesswork, I would say, but generally what you want is you want to see a good shape of the head. So if you come here, you see a lot of neck also. If you come here, it's a very lateral portion of the head with just a round circle. So you want to see a little bit of head and neck, like almost like a good shape like that, or more like this. So at this point, it's a simple angle. You go from here to the center and then go to the sourcil. So here's the sourcil finishing. You do it there. It's about 56 degrees. So this is more for anterior under or over coverage, which you will also see on the false profile view. And this is the AP center edge angle. Now what are the measurements? It's the same. It's usually 20 to 40 degrees. So more than 40 degrees we are thinking of over coverage, while less than 20 degrees is under coverage. So when you get an angle of about 56 degrees or so, they may have a little bit of retroversion, which is over covering the anterior portion of the head. So again, we'll take that image to our output panel. And once we are done with these measurements, now the next measurements are more about the acetabulum and how the femur is anterior retroverted and what's the neck shaft angle. So let's start with the simpler one. That'll be your neck shaft angle. We'll come here. We'll scroll through that. And if you're interested in only right side, we'll just focus on that. And we go to our measurement palette. Again, get the angle out through the neck and then through the shaft. So here we get about 140 degrees and the normal is about 120 to 140 degrees. So this is within normal limits. So there is not much coxa vara or coxa valga. Okay. The next measurement, we'll take a picture of that. The next measurement we'll go through is the femoral version. Now for the femoral version, ideally it should be corrected with the knee version as well. And I'll show you the knee image later. Maybe we can skip to acetabular measurements first because they just require this format and we can do it without the knee image in the plane. So for the acetabular version, now you're looking at the acetabular clock phase, which is this one. So this is your 12 o'clock, 6 o'clock, 3 o'clock anterior, 9 o'clock posterior. So at this point, we bring it to 1 o'clock, which is about that. And we are looking at this axial image. And you can see there is some retroversion there, meaning the anterior wall is longer than the posterior wall. So this acetabulum is facing back, retroversion, versus most of the acetabulum will face anteriorly. So these kind of acetabula can predispose to posterior subluxation of the femoral head, and patients can feel instability when they're walking. So now, to measure that angle, it's pretty straightforward. You basically take the anterior wall, take the posterior wall, and then draw a straight line there. So here, because it's retroverted, the wall measurement is going outside to the right of that. Usually it's antiverted, goes on this side. So this measures about 3.4 degrees of retroversion. The normal measurement is more than 5 degrees of antiversion, but here we are looking at about 4 degrees of retroversion. Now you do have to exclude if they're osteophytes, if they're labral calcification, you do have to exclude that stuff when you do your measurements. And how do you distinguish a wall from a column? The wall has no marrow, so these little spikes are walls, and the columns have most of the marrow, so these are columns. Okay, the wall is just this small portion. If there's osteophyte, you have to exclude it. Now, so you got that measurement at 1 o'clock, you take that picture, you can just bring it down right here at about 2 o'clock. And at that point, you should start to see a little bit of the fovea, not too much, just starting of the fovea. So at this point, you can just adjust it, and here it goes this way. and let's connect this. It's like this, and then you bring your straight line, and you can see it's only 1.4 degrees of anteversion, while in normal patients it should be more than 10 degrees. So there is still some retroversion happening here, very small amount of anteversion, so that's not good. Then we go to 3 o'clock, which is here, which is right about this physeal scar, and that's where you should see the fovea also. In this case, we are not seeing the fovea much because the fovea is also high. That's called fovea alta. You can see this fovea, it's kind of higher than that plane. Usually you should see a fovea at 3 o'clock. So now you can do this measurement again. So again, this connect this line to that line, and this is your straight line up. So you have about 11 degrees, and in normal subjects it should be more than 15 degrees. So to recapitulate, more than 5 degrees at 1 o'clock, more than 10 degrees at 2 o'clock, and more than 15 degrees at 3 o'clock. While here what we have is mostly retroversion, minimal anteversion at 2 o'clock, and small amount of anteversion at 3 o'clock. So this hip is more retroverted. So that's how you will do acetabular versions. Okay, so now we'll learn how to measure the femoral version and acetabular version. So let's do the femoral version first. So this is how I've loaded the image. I'm going to magnify, and then this is our angle tool here. So what we'll do is first we go to the center of the head, which is this area, and then we'll keep scrolling till we get to the center of the greater trochanter. So this is the center of the greater trochanter, and about there, and then we draw a straight line across that. And basically it gives us about let's say 16 degree angle or 15.9 degree angle, and that angle, we'll take a picture of that. And in order to correct this with the knee rotation, we'll have to look at the knee later, but let's look at the pelvic tilt for the time being. So I'm going to delete this, and now we go to the ischial tuberosity, and you can see there are some enthesophytes here, but in general it's quite straight. So we'll take that ischial tuberosity angle. So in this case it goes a little bit towards that. So if you make it straight, it's almost neutral. It's like 0.9 degrees with right side up, and on the femoral side it was anteverted about 16 degrees. So that's our pelvic tilt angle. So now we're going to use this pelvic tilt angle to correct the acetabular version. So we can go back to our acetabular version. So say at this point, which was close to our 1 o'clock, if the anterior to posterior acetabular connection with the vertical, which is our acetabular version at 1 o'clock, seems 9.5 degrees anteverted, and you can see the pelvis is also tilted to the right. So if you tilted the pelvis back to normal, in this case 0.9 degrees down, so you'll have to subtract that 0.9 degrees from 9.5 or 9.6. So that'll become 8.5 degrees of acetabular version. So that's how you'll correct for 1 o'clock, 2 o'clock, and 3 o'clock. And now we'll move to the knee to correct for the femoral version, which we had about 16 degrees. So we'll have to load the knee. Okay, I've loaded the knee here, which you can see in all 3 planes as well as the volume rendered image. And we're going to work on this axial image and magnify it. So I'm going to use the angle tool again and scroll down or scroll up wherever I can see the good notch as well as the femoral cartilage, which is thickest. So this looks like, where it's thickest, and we have nice femoral condyles. So I can take the angle here, and you can see it's a little bit tilted to this direction, almost straight. So if I do that, it's very little tilt. So in this case 0.8 degrees, and 0.8 degrees it's going towards the left. Now if you remember the femoral version, that was anteversion. So in order to correct for the femoral version, if I move this up to make it horizontal, I'll have to lose 0.8 degrees, and then my femoral version, which is anteversion, will become a little bit less than 16 degrees. So it was 16 minus 0.8, which will make it about 15.2, or if you take exact, then you can subtract the exact 0.87 and come up with that version. So that's how you'll correct the femoral version relative to the knee version, and that'll be your actual femoral version. So the normal femoral version is about 15 degrees or so. So in that case, it's almost normal. So I think that concludes our section, and now you all know how to do the measurements, how to do the segmentations, but you got to watch both the parts, part 1 and part 2, and you'll be expert in this, and you can help your hip surgeons in your town, and they'll be happy with it. I'm pretty sure about it. Thank you.